One of these 4 tasks is a scope violation waiting to happen. It looks almost exactly like the safe one sitting next to it. 30 questions on delegation and scope, the section that quietly ends more NCLEX attempts than any drug. Every option is something a nurse could hand off. By the end, you will know exactly who can do what and who cannot. Who can do this? Is it stable, predictable, routine? Who stays accountable? Let's begin. Before the questions, the rules. Delegation looks like common sense until the exam hands you 4 tasks that all sound fine. What separates the safe handoff from the lawsuit is scope, and scope has hard edges. Let's draw them. The unlicensed assistive person, the UAP. 1 test, 3 gates. Is the task stable? Is it predictable? Is it routine? If any gate fails, it is not a UAP task. And a UAP never assesses, teaches, evaluates, triages, or cares for an unstable client. Here is the rule under all the others. You delegate tasks. You never delegate the nursing process. Assessment, diagnosis, planning, and evaluation belong to the RN. You can hand off the doing. You can never hand off the judging. I'm umbilian saying a suffixing tenstry as missenses. The LPN or LVN sits in the middle, and their scope varies by state, so know your own. In most states they give oral, subcutaneous, and intramuscular medications, reinforce teaching, change dressings, and care for stable clients. What they generally cannot do: IV push, hang blood, do the initial assessment, or start the teaching. So, what stays with the RN, always? The nursing process, the unstable client, blood administration, IV push and drip titration, triage, and the initial teaching. If a task touches any of those, it does not move. When you do delegate, 5 rights make it safe. Right task, right circumstance, right person, right direction, meaning you say exactly what to report and when. And right supervision, meaning you follow up and evaluate. Right person is the one students miss. It means 2 things at once: in scope and competent for this specific task. A worker who has never done this particular procedure should not be forced, even if it is technically within their scope. The line that governs every handoff. When you delegate, you transfer the task, but you keep the accountability. If it goes wrong, it is still yours. That is why supervision is an action, not an assumption. Every one of the 30 items is timestamped in the description by type and topic. Jump to the boundary. You keep missing. Now, question 1. First, the UAP. Run every task through the 3 gates. Stable, predictable, routine. Watch how often the exam hides an assessment inside a chore. RN is deciding which task to hand off to the UAP on a telemetry unit. Each task below could be done by someone, which is most appropriate to delegate to the UAP. Routine vitals on a stable client is stable, predictable, and routine, the 3-part UAP test, and requires no clinical judgment. It is the only task here that clears all 3 gates. So the answer is B. Assessing new shortness of breath is the reflex. A UAP takes vitals so they can check breathing, but new symptoms require assessment, an RN function. Delegate it, and a decompensating client is evaluated by someone who can't interpret the finding. Teaching a pulse check is initial teaching. The RN or LPN reinforces. The UAP never teaches. A UA. Judging a drug's effect is evaluation. A UAP takes vitals, but they don't interpret them. The gate is the verb. Measuring is delegatable. Assessing is not. A client 1-day post-op total knee arthroplasty is stable. Select all tasks the RN can delegate to the UAP. Compression devices, commode assist with output recording, and routine vitals are stable, predictable, routine physical tasks fully within UAP scope. The correct selections light up now. Assess the dressing for the first signs of bleeding, hides an assessment verb inside an observation task. A UAP may report what they happen to see, but the nurse owns the assessment, so it is not delegated. Feeding a client on aspiration precautions is not routine. It needs the nurse's judgment and monitoring. Reinforcing discharge teaching is a teaching function, LPN or RN, not a UAP task. Delegation items bury an assessment or teaching verb inside a list of chores. The verb decides scope. The verb decides scope, not the setting. On a neuro unit, classify each task as delegate to UAP or keep with the licensed nurse. One task that produces a number is not a delegible measurement. Feeding after a past swallow screen, repositioning, and collecting an already voided specimen are routine physical tasks. The Glasgow Coma Scale and pupil checks are neuroassessments of a changing client. The nurse keeps both, even though they yield numbers. That is how each task is classified. The Glasgow Coma Scale is the buried trap. It looks like a routine number a UAP could check the way they check vitals, but it is a clinical assessment of a changing neuro status. Delegate it and a decline goes unnoticed by someone who can't grade it. Pupil checks on a new bleed. Monitor an unstable client, so RN. Feeding is delegible only because the swallow screen was passed. A task that yields a number is not automatically a UAP task. Assessing a changing client stays with the nurse. The UAP offers to help with a client who had a new colostomy created 2 days ago. Which task should the RN perform rather than delegate to the UAP? A new stoma still needs assessment. Stoma color and peristomal skin integrity are ongoing evaluations of a fresh surgical site. The RN performs the early pouch changes until the site is established and the picture is predictable. So the answer is D. Emptying an established pouch on a stable client is routine and delegible. The trap is assuming all ostomy care is RN level. It is the newness, not the task, that keeps this one with a nurse. Recording output the client empties is routine. Water and repositioning are basic comfort care. Routine is a status, a task earns. New surgical sites are the nurse. Until they're established, then they become delegible. Exam Pearl. Watch the verb assess, teach, evaluate, and triage never leave the licensed nurse, no matter how routine the task sounds around them. On a busy psychiatric unit, the RN is delegating to the UAP. Which task is most appropriate to delegate? Accompanying a stable client on a routine supervised walk is a predictable, non-judgment task within UAP scope. The client is stable, and the activity is scheduled and structured. So, the answer is A. 15-minute safety check sounds like a simple rounding task a UAP could do, and a UAP can observe and report, but judge the client's suicide risk converts it into an assessment. The risk determination stays with the nurse. Reinforcing taught coping skills is a teaching function. De-escalating rising agitation is managing an unstable client, both RN or licensed. A UAP can watch and report, but never judge. If the task ends in a clinical determination, it isn't a UAP task. Now the harder line, UAP versus LPN. When does a task need a license, and when does it climb all the way back to the RN? RN is dividing tasks between an LPN, or LVN, and a UAP. Which task is best assigned to the LPN or LVN rather than the UAP? Administering insulin, a medication, and observing for its effect requires a license, within LPN or LVN scope in most states, and beyond UAP scope. It goes to the LPN, not the UAP. So, the answer is B. Sending the med to the UAP, because it's just a shot, is the trap. UAPs do not administer medications. That would be an unlicensed med pass reaching the client. A fingerstick on a stable client, recording intake, and hygiene are all appropriate UAP tasks. Delegation tests scope, not difficulty. A simple med still needs a licensed giver. Match the license to the task. An LPN or LVN and a UAP are working with the RN on a med-surg unit. Which task requires the RN and cannot be delegated to the LPN or LVN? The initial admission assessment and creation of the plan of care are nursing process steps reserved for the RN. You delegate tasks, never the nursing process. So, the answer is C. Track care looks like the RN level task because it involves an airway, but on a stable client, it is within LPN scope in most states. The trap is confusing complexity with the nursing process. The admission assessment, not the track care, is RN only. Giving a scheduled oral antibiotic and reinforcing, not initiating, teaching, are within LPN or LVN scope. Complexity of a task is not what makes it RN only. The nursing process is RN only. Skilled tasks can go to the LPN. Classify each task by the lowest level worker who can appropriately perform it. UAP, LPN, or LVN, or RN. Only LPN and LVN. Scope varies by state. Routine vitals on a stable client goes to the UAP. The IM antibiotic and a protocol dressing change go to the LPN or LVN. Developing the care plan and initial teaching are RN only, the nursing process. That is how each task is classified. Initial teaching is the trap that drifts down to the LPN, but LPNs reinforce teaching, they don't initiate it. The first teaching of new content is the RNs. Med administration and stable wound dressing changes are classic LPN tasks, state-dependent. Delegate down to the lowest safe level, but the nursing process never moves off the RN. It is a short-staffed shift. The charge RN must reassign one task. Which task? If the LPN or LVN is asked to do it, should the RN question before reassigning? Administering blood is generally outside LPN, or LVN scope, an RN function in most states. Even under staffing pressure, the RN keeps it. Staffing convenience does not expand a license. So the answer is A. Under staffing pressure, the reflex is to push the big task down to free the RN, but blood administration is exactly the task that cannot move. Reassign it, and the client gets a transfusion started by someone outside scope. Catheter insertion, oral or IM meds, and bladder scanning are within LPN or LVN scope. Verify state rules. Short staffing tempts you to delegate up to the LPN's limit and past it. The license line doesn't move when the unit is busy. Short staffing never expands a scope. When the unit is slammed, is exactly when the license lines matter most. The RN is assigning tasks to an experienced LPN or LVN on a cardiac step-down unit. Select all tasks that are appropriate to assign to the LPN or LVN. LPN scope varies by state. Scheduled oral meds, reinforcing prior teaching, monitoring a stable client, and a protocol dressing change are within LPN or LVN scope in most states. The correct selections light up now. Pushing IV adenosine and titrating a vasoactive drip are the traps. IV, push antiarrhythmics and drip titration require RN-level judgment for a changing client, and sit outside LPN scope in most states. Assign them and an unstable rhythm is managed beyond scope. IV push and vasoactive titration are RN functions. Reinforcing, not initiating, teaching is LPN appropriate. LPNs handle stable and scheduled. The moment a task is IV push titrated, or for an unstable client, it climbs back to the RN. What must the RN keep? These items are 1. Test. Is it the nursing process or an unstable client? If either answer is yes, it does not get delegated. On a pediatric unit, the RN has an LPN or LVN and a UAP. Which task must the RN keep and not delegate to either? Evaluating the effectiveness of the pain plan is evaluation, a nursing process step that stays with the RN. Judging whether the plan works requires the RN's clinical judgment, so the answer is B. Giving the analgesic looks like the important task to keep, but administering a scheduled med is delegible to the LPN. It's the evaluation of the plan, not the act of medicating, that is RN only. Routine vitals and transport of a stable child are UAP tasks. You can hand off the doing but not the judging. Evaluating whether care worked is always the nurse's. The RN is about to delegate several tasks. Which delegated task contains a hidden step that actually requires the RN? The walk itself is delegable, but decide on oxygen embeds a clinical decision the UAP cannot make. The buried judgment step, titrating oxygen to a symptom, belongs to the RN. The UAP can only walk and report. So the answer is A. Recording a weight looks like the odd one out, but it is a plain measurement fully within UAP scope. The trap is the reasonable sounding walk order that quietly hands a clinical decision to an unlicensed worker. Administering a scheduled inhaler is LPN appropriate. Showering and linens are UAP care. Read the whole instruction. A delegable task can smuggle in a judgment call. The decision stays with the nurse. A postpartum RN is delegating on a busy shift. Select all tasks that must be kept by the RN because they involve the nursing process or an unstable client. The initial assessment. Assessing a boggy fundus or heavy lochia. An unstable, changing finding. Initial safe sleep teaching. And evaluating the massage's effect are all nursing process or unstable client tasks, so RN kept. The correct selections light up now. Recording vitals on a stable client and assisting a stable client to the bathroom are the buried delegable tasks in the list. They look similar to the RN tasks but involve neither the nursing process nor instability, so they go to the UAP. Assessment, initial teaching, evaluation, and unstable client care are the 4 RN anchors. Sort the list by 2 questions. Is it the nursing process, and is the client unstable? Either yes means the RN keeps it. A client with new diabetes needs several tasks done. Classify each as delegate to UAP, LPN, LPN or LVN, or RN only. LPN or LVN scope varies by state. Fingerstick on a stable client goes to the UAP. Reinforcing prior teaching and giving insulin go to the LPN or LVN. Initial teaching and evaluating readiness to self-manage go to RN only. That is how each task is classified. Reinforce the technique the RN already taught looks like RN teaching, but reinforcement of already taught content is an LPN function. Initial teaching, carb counting, is the RN's. Reinforcing is not. Evaluating readiness is evaluation, RN only. A fingerstick is a routine measurement. The same verb, teach, hides 2 scopes. Initial teaching is RN only. Reinforcing already taught content drops to the LPN. Teaching splits in 2. The RN does the initial teaching. The LPN reinforces it. The UAP never teaches at all. Client returned from an endoscopy 30 minutes ago and is still drowsy from sedation. The UAP asks how to help. Which task should the RN keep for now rather than delegate? The first post-sedation oral trial is an assessment of a changing status. The RN must verify the gag reflex and safe swallow before intake. It is not yet predictable, so the RN keeps it until swallowing is confirmed. So the answer is C. Emptying the urinal looks like the obvious UAP task, and it is. The trap is assuming everything for a drowsy client is the RN's. It's the swallow check, not the routine care, that must stay with the nurse right now. Routine vitals with reporting and helping a fully awake client change are within UAP scope. After sedation, the first swallow is an assessment, not a chore. It becomes delegible only once the client is fully awake and stable. Making the assignment. Delegation sorts tasks. Assignment sorts clients. The stable and predictable client goes to the LPN. The changing one stays with the RN. Charge RN is making client assignments for an LPN or LVN. Which client is most appropriate to assign to the LPN or LVN rather than to an RN? A stable client awaiting reinforcement of teaching is predictable and within LPN scope. Assignment matches the most stable, predictable client to the LPN and keeps the changing clients with the RN. So the answer is C. Under staffing pressure, the reflex is to hand a busy post-op client to the LPN to free the RN. But a new chest tube with fluctuating vitals is unstable. Assign it to the LPN, and a changing client is watched by the wrong level. Worsening dyspnea and a new BiPAP titration are unstable or evaluation situations, so RN clients. Assignment sorts clients the way delegation sorts tasks. Stable and predictable goes to the LPN, changing stays with the RN. For delegating wound care to an LPN or LVN, place the RN's delegation steps in the correct order. The delegation process follows the 5 rights in order. Verify the right task or right person, give right direction. The worker performs, the RN supervises. Then the RN evaluates. Direction comes before the task, and evaluation comes after. That is the correct order. Skipping straight to have the LPN do it is the trap. Without confirming scope and giving clear direction first, you've delegated blind, and the RN still owns the outcome. Direction precedes doing. Supervision and evaluation are not optional final steps. Accountability for the outcome remains with the RN. Delegation isn't handed off and walk away. You direct before, and you evaluate after, because accountability never transfers. A float RN from the ICU is assigned to a busy medical unit. Which client assignment is most appropriate for the charge RN to give the float nurse? A float nurse should get the assignment that best matches transferable, high acuity skills. A telemetry client is squarely within an ICU nurse's competence, assigned to strengths and to what doesn't depend on unit-specific knowledge. So the answer is D. The intuitive move is to give the float the simplest or the most complex clients. But clients needing unfamiliar unit protocols and complex discharge coordination set a competent float up to fail. The mismatch is unit-specific knowledge, not skill. Detailed discharge coordination and socially complex assignments depend on knowing the unit and its resources. Assign a float to what their skills transfer to, the acuity they know, not to what depends on knowing this specific unit. On a short-staffed ortho unit, classify each proposed assignment as appropriate or inappropriate for the worker named. LPN, scope varies by state. Ambulating a stable post-op client, giving scheduled oral meds by the LPN, and applying ice per order are appropriate. The first neurovascular check on a new cast is an assessment, so RN, and the admission assessment is the nursing process, so RN, both inappropriate to assign down. That is how each task is classified. Under staffing pressure, the neurovascular check gets pushed to the UAP because they check things. But the first assessment of a fresh cast detects compartment syndrome, an RN assessment. Staffing doesn't lower the bar. Scheduled oral meds are LPN scope. Staffing for leonid fichtbegrieve eyes at cry care neurogold eyes at every care. Ice or elevation per order is routine UAP care. Being busy never expands a scope. The first assessment of anything new is the RN's. Staffing crisis or not, you delegate tasks, never the nursing process. Assessment, diagnosis, planning, and evaluation stay with the RN. Every time, the UAP is helping with a client who returned from hemodialysis 20 minutes ago. Which task should the RN keep rather than delegate right now? Immediately post-dialysis, the client can be hypotensive, and the vascular access must be assessed for bleeding and a bruit or thrill. This is an RN assessment of a still-changing status. It becomes delegible once the client is stable. So the answer is A. Emptying the urinal is the obvious UAP task, and it is. The trap is assuming the whole post-dialysis client is the RN's. It's the hemodynamic and access assessment, not the routine care, that the RN keeps right now. Delivering an approved snack and settling the client in bed are routine UAP tasks. Right after a high-risk procedure, the assessment is the nurse's. The routine chores around it can still be delegated. I'm vad. The routine corn of de hardgens I miles for pas and controllands to see. 5 Rights of Delegation. Right task, right circumstance, right person, right direction, right supervision. The two students forget are direction and supervision. A UAP is about to take vital signs on several clients. Sequence, what the RN should do to delegate this safely and completely. Safe delegation isn't just handing off the task. Verify the circumstances right, give specific report parameters, let the UAP perform, review the results, and act on abnormals yourself. The buried step students skip is defining which values to report. That is the correct order. Jumping to let the UAP take the vitals without setting report parameters is the trap. A UAP will record an ominous value without flagging it if you never said which numbers matter. The direction step is what makes the delegation safe. Reviewing and acting on abnormals is the RN's retained accountability. The task moves, the responsibility doesn't. The hidden half of delegating is telling the worker exactly what to report. Without it, a red flag value gets charted, not called. RN delegates ambulate the client to a UAP for a client 6 hours post-cesarean. Which detail makes this delegation unsafe as stated? Ambulation is delegable, but the first ambulation after a cesarean carries orthostatic and fall risk. The RN must give specific direction, the assist level, and what to watch for, or establish tolerance first. The failure is missing direction, not the task itself. So the answer is C. Ambulation is never in UAP scope is the trap. It overcorrects. Ambulating stable clients is a classic UAP task. The problem here is the unestablished first walk with no direction, not the activity. It isn't RN only, and the LPN isn't required. The fix is proper direction and establishing the first ambulation. Most bad delegation isn't the wrong task. It's the right task, handed off with no direction. Say the assist level and the red flags. The RN is delegating feeding of a stable toddler to a UAP. Select all elements the RN must communicate for the delegation to meet the right direction standard. Right direction means the specifics the UAP needs to do the task safely. What and how much to feed, positioning and choking precautions, what and when to report, and clear stop and call criteria. The correct selections light up now. Sharing the RN's full clinical reasoning and the child's diagnosis or prognosis is the over-delegation trap. It's neither necessary for the task nor within the UAP's role, and it blurs the scope line. Direction is task-specific, not a case conference. Positioning, report parameters, and stop criteria are the core of right direction. Delegate the what and the when to report, not the why. The UAP needs instructions to act, not the nurse's reasoning. After delegating a task to a UAP, which action best fulfills the RN's right supervision responsibility? Right supervision means the RN follows up on the delegated task and evaluates the client's response, because accountability for the outcome stays with the RN even after the task is handed off. So the answer is D. UAP is experienced, so assume it's done, is the intuitive shortcut and the exact failure. Experience doesn't transfer the RN's accountability. Supervision is an action, not an assumption. Documenting the delegation isn't supervision. Delegating a check to another UAP doesn't discharge the RN's responsibility. You can delegate the task, but not the accountability. Supervision is following up on purpose, not trusting by default. You can delegate the task, but never the accountability. If it goes wrong, it is still the nurse's, so supervise, on purpose. RN must delegate, obtain the 11:30 fingerstick and give the ordered lunchtime insulin, and the team available is a UAP plus an LPN or LVN. Build the bow tie for delegating this correctly. Split the task by scope. The fingerstick, a measurement, goes to the UAP with a report back value. The insulin, a medication, goes to the LPN. The RN monitors the reported glucose before insulin and watches for post-dose hypoglycemia. Those are the two right actions, and the two things to monitor. Delegating the insulin injection to the UAP to save time is the right idea, wrong worker trap. It's efficient, but a scope violation. A UAP never administers insulin, even when the unit is rushed. Glucometer supply and daily weight are irrelevant to this delegation. The RN's follow-up is not optional. When one order contains two tasks, delegate each to the right level. The fingerstick and the insulin don't go to the same person. Gauntlet. Staffing pressure, competence gaps, and a delegated task that goes wrong. Everything at once, no scaffolding. A UAP reports, I gave the client their bath and they said they feel dizzy and their heart is racing. Which is the RN's best response? UAP, reporting a new symptom, is exactly the handback point. The RN must personally assess the changed client. The UAP did their job by reporting. Interpreting and acting on the change is the RN's. So the answer is B. Asking the UAP to gather vitals and call back looks efficient and appropriate delegation, but it delays the RN's assessment of a client who is actively changing. The report of a new symptom is a cue to go, not to delegate further. Having the UAP reassure or documenting for later both leave a changing client evaluated by no one qualified. When the UAP reports a new symptom, the delegation is over. That's the moment the RN goes and assesses. An LPN or LVN tells the RN, I don't feel comfortable doing this tracheostomy suctioning. I've never done it on this. What is the RN's best action? Even when a task is within scope, the right person must be competent for this situation. A worker who states they aren't competent for this specific task should not be forced. The RN does it, or directly supervises. Scope and competence are both required. So the answer is D. It's in your scope, so do it is the intuitive but unsafe answer. Scope permits the task, but competence for this specific track is what makes it safe. Forcing it risks the client and ignores a legitimate competence gap. Reassigning without addressing competence just moves risk. Documenting a refusal mislabels an honest competence concern. In scope isn't enough. If the person isn't competent for this task, the RN does it or supervises. You never force it through. During a busy shift, the RN considers several handoffs. Select all that would be inappropriate delegation. Appropriate. A UAP relaying biopsy results, communicating clinical information or teaching. An LPN developing the care plan, the nursing process. An LPN triaging, an RN assessment. And a UAP judging whether a wound looks infected, an assessment. The correct selections light up now. The two buried appropriate tasks, recording intake and output, and obtaining vitals on stable clients, sit next to the inappropriate ones, and look similar, but they are plain measurements within UAP scope. The trap is that, check the wound and let the family know sound, casual, but embed assessment and clinical communication. Triage is RN-level judgment. Care planning is the nursing process. Disclosing results is not a UAP role. Casual wording hides scope violations. Just tell them the results and check if it's infected. Are assessment and disclosure in disguise. UAP delegated to ambulate a stable client returns saying the client became very short of breath and clutched their chest in the hallway. Sequence the RN's actions. The delegated task ended the moment the client changed. The RN goes and assesses ABCs first, rests or oxygenates, gets vitals and an ECG, notifies the provider, then documents and debriefs the UAP. Emergency assessment and stabilization come before documentation. That is the correct order. Starting with the event note or reviewing the delegation with the UAP is the trap. Accountability means you go to the deteriorating client first. Documentation and debrief are last, after the client is stabilized. Oxygen and ECG follow the initial assessment. Provider notification carries the data you've gathered. When a delegated task goes wrong, the RN owns the outcome. You go to the patient first, and the paperwork comes last. Right person means two things: in scope and competent for this specific task. In scope but never done it, the RN does it or directly supervises. A charge RN on a short-staffed stroke unit must cover an unstable new admission, while 5 stable clients need routine care. Build the bowtie for safe assignment and delegation under staffing pressure. Under staffing pressure, the RN keeps the unstable client and the assessments, and delegates only the stable, routine care to the UAP with clear report back. Safety governs over efficiency. The crisis changes the workload, not the scope lines. Those are the two right actions and the two things to monitor. Assigning the unstable admission to the LPN or the stroke scale to the UAP to free the RN is the efficiency trap. It moves an unstable client and an assessment below the required level. Short staffing is exactly when scope discipline matters most. Linen levels and next week's schedule are noise. The RN monitors the unstable client and the UAP's report backs. Short staffing pushes you to delegate past the scope line. Delegate the routine, keep the unstable and the assessments, always. 30 handoffs. If you keep only 3 lines, keep these. You delegate the task, never the nursing process. Stable, predictable, routine is the UAP test, and an assessment verb breaks it, and the accountability never transfers, even when you do. Timestamps for all 30 are in the description. Jump to the boundary you keep missing, and tell me in the comments, which one would you have gotten wrong? Drop the number below and I will break it down.